Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient says, "Doctor, I see two images when I walk downstairs, and it is worse when I look down to read." That is a classic setting where you should think about a fourth cranial nerve palsy. IRV is the trochlear nerve. It supplies one muscle, the superior oblique. So, CNIF palsy means superior oblique weakness. The superior oblique normally helps the eye intort, and it depresses the eye, especially when the eye is adducted. When it is weak, the affected eye loses depression in adduction and loses intorsion. The result is vertical or torsional binocular diplopia, classically worst when looking down and in. To understand this properly, think in three simple boxes: the muscle action, the patient's symptoms, and the anatomical course of the nerve. First, the muscle action. The rectus muscles are easier to remember because they mainly move the eye up, down, medially, and laterally. But real eye movements are not robotic straight-line movements. The oblique muscles fill in the diagonal and torsional control. The superior oblique is particularly important for looking down when the eye is turned inwards. That is why patients with superior oblique palsy struggle with reading, descending stairs, or looking down while walking. Now connect that to the clinical picture. If the right superior oblique is weak, the right eye cannot depress properly when adducted. It also cannot intort properly, so the right eye tends to sit relatively higher and extorted. This causes vertical and torsional diplopia. The key clue is that the diplopia becomes worse in down gaze, especially when looking down and towards the opposite side. In a right CNI4 palsy, diplopia is usually worse when looking left and down. Another important clue is head tilt. Patients often tilt the head away from the affected side. This is not random. Head tilt away from the weak superior oblique reduces the need for intorsion and helps the brain fuse the images. Head tilt towards the affected side makes the diplopia worse. MRCP trap. A patient with a chronic head tilt may have a congenital fourth nerve palsy that has decompensated later in life. Now let us move to anatomy, because the course of the fourth nerve explains the causes. The trochlear nucleus lies in the dorsal midbrain at the level of the inferior colliculus. The fibers then decussate before exiting. This is high yield. A nuclear fourth nerve lesion causes a contralateral superior oblique palsy. The fourth nerve is also unique because it is the only cranial nerve to exit from the posterior aspect of the brainstem. After leaving the dorsal brainstem, the nerve has a long, thin subarachnoid course around the midbrain. That makes it vulnerable to trauma and raised intracranial pressure. It can also be affected by meningitis, subarachnoid hemorrhage, and microvascular disease such as diabetes or hypertension. Then it enters the cavernous sinus, where it runs in the lateral wall with cranial nerves 3, V1, and V2. So if the fourth nerve palsy occurs with pain, ophthalmoplegia, facial sensory symptoms, proptosis, or multiple cranial nerve signs, think beyond an isolated microvascular palsy. Consider cavernous sinus thrombosis, internal carotid artery aneurysm, Tolosa-Hunt syndrome, pituitary apoplexy, or tumor. From there, CNI4 passes through the superior orbital fissure and reaches the superior oblique muscle. At this stage, orbital disease can mimic a fourth nerve palsy. Do not confuse this with thyroid eye disease, orbital myositis, Brown syndrome, or mechanical restriction. Clinically, the typical finding is hypertropia of the affected eye. There may be excyclotorsion, and the patient describes binocular vertical or torsional diplopia. Binocular is important. If either eye is closed, the diplopia disappears. A right CNI4 palsy gives right superior oblique weakness, right hypertropia and diplopia that is worse looking left and down, and worse with right head tilt. For diagnosis, use the Bielschowsky 3-step test. First, ask, which eye is hypertropic? Second, ask, is the hypertropia worse in left gaze or right gaze? Third, ask, is it worse with left head tilt or right head tilt? This helps localize the weak cyclovertical muscle. But remember the dangerous mimics: skew deviation, thyroid eye disease, myasthenia gravis, orbital restriction, and partial third nerve palsy. Management depends on the context. For acute symptoms, use simple measures such as occlusion, Fresnel prism, and avoiding driving while diplopic. Then treat the underlying cause. An isolated presumed microvascular fourth nerve palsy in a patient with diabetes or hypertension may be observed if the presentation is otherwise typical. But urgent neuroimaging and neurology or neuro-ophthalmology review are needed if there are other neurological signs, papilledema, severe headache, trauma, cancer history, progression, bilateral signs, or failure to improve. If the palsy becomes persistent and stable, long-term prism or strabismus surgery may be needed. If you remember one thing, remember this. Fourth nerve palsy is superior oblique weakness, causing vertical or torsional binocular diplopia that is worse than down gaze, especially when looking down and in. Quick recall. A patient has right hypertropia and binocular vertical diplopia that is worse when looking left and down, and worse with right head tilt. Which nerve is affected and which muscle is weak? The answer is the right trochlear nerve, causing right superior oblique weakness. A patient has an apparent fourth nerve palsy, but also has severe headache, papilledema, and progressive symptoms. What is the management trap? The trap is to label it as benign microvascular palsy. This patient needs urgent neuroimaging and specialist review because raised intracranial pressure or a structural lesion must be excluded. Do subscribe to the channel for further videos.